welcome back. It's time for one of your favorite sessions, Ask the Experts. As a reminder, please limit your questions to 1 minute. And please welcome back to the stage Dr. Cannon and Dr. Harr. All right, gang. And so for our live audience, I'll run around and talk to you or you can, if you got the Whova app uploaded, you will see that there is not a QA feature in this, and so we're just going to roll with it. And if you're remote, then you want to use the chat feature instead, and so you can just post your questions in chat, and we will try to get to as many as possible. We have a hard stop for Dr. Cannon at 12. He's going to make a flight. We're not going to make him late for his flight after all that he's invested in us, and so he's just walking off the stage at 12 no matter what. And if we keep going, we'll keep going. All right, here's how it goes. I'll start with this one. When doing pelvic PT this year, I noticed that the biofeedback machine used by the PT showed how much and how fast my pelvic muscles would tire out when used. I noticed it seemed similar to what it is tested in a CMAP long exercise test. Is there any real similarity?
So exercise is a very well-known trigger for inducing an episode of weakness and periodic paralysis, but usually that requires vigorous exercise for many tens of minutes. I don't know exactly how long this PT exercise event is, but that would be unusual. So a symptom that changes more rapidly with repeated contractions is myotonia. So there's a very famous warm-up where that relaxes over a matter of tens of seconds. But I wouldn't attribute the reported experience to necessarily the same thing that's going on during a CMAP test.
Okay, and for humans, they asked about mice. Do mice have pelvic muscle issues? And for humans, is there a certain age, how young is normal to start having problems with pelvic muscles versus people with PP?
So the mice, there's no evidence, there's no prolapse, they breed just fine, there's no episodes there. I haven't seen, the only issues I've seen in terms of regional problems for muscle and periodic paralysis is more the late onset, slowly progressive permanent muscle weakness, which preferentially affects the legs and axial muscles more than the distal muscles. But I haven't, I'm not aware of specific issues with pelvic floor muscle groups.
Okay, and I'll tell you what, gang, if you can, just for our audience, if you can, because we're using chat, the live audience less so because you'll get to ask your question, but for those remote or using the chat app, if you can just put Dr. Harr, Dr. Cannon, or you can leave it open, but that would make it a little bit easier because there's a lot going on in the chat. All right, how does having PP, I suspect I have ATS, affect the soft tissue structures around the muscles? Could it cause multiple tendon injuries or chronic tendinopathies that are stubborn to heal as we are demanding a lot of muscles that aren't working at 100%, especially for athletic, or spend a lifetime competing and pushing through weakness without realizing we had PP? I have had a proximal hamstring tendinosis that hasn't healed over 2 years of therapy, as well as many other tendon injuries over the years.
So as a general principle, individuals with muscle disease, with myopathies, including periodic paralysis, can have secondary joint issues. So we've discussed a little bit today that hypermobility is often seen, and dislocations and subluxations have occurred at higher frequency than in the general population. So it's certainly plausible. But it's not such a consistent finding that we have advice for restricting activities or participation in sports for people with periodic paralysis.
Okay. And just a warning for those at home, every time I get a question, it throws up the chat feature, so I lose where I'm at, so we'll do our best on this. I think we covered this yesterday. How do we keep up with XEN? And we'll just Google that. For people with hyper PP, carbs are supposed to be beneficial unless consumed in large amounts late in the day. Can you expand on this and provide clarity on how much could be too much late in the day?
So I wish our dietitian were still here, but the general principle is that when you eat starch or sugar, starches break down into small sugars. those get taken up primarily into muscle and liver, and in that process, potassium gets moved to the intracellular compartment. So you can have a substantial decrease in the blood potassium by maybe 0.5 or 1 milliequivalent per liter after a carbohydrate load, and it only takes a couple hundred grams of carbohydrate. So, it gets into interesting questions of individuals who might have episodes upon a first awakening and thinking about timing snacks late at night for hyper-PP and things like that. But I think you just have to use personal experience as a guide there.
Okay. I have paramyotonia congenita with hypokalemic periodic paralysis. I've been told this is rare since it's usually hyperkalemic. Acetazolamide severely worsened symptoms. Amelioride alone didn't help. Now on amelioride plus eplerenone, but potassium stays around 3.5. I was told not to take oral potassium due to both drugs being potassium sparing. Do you have any recommendations?
So when you started out, it went a little fast. Thought initially to be paramyotonia congenita and then change in diagnosis?
Yeah, I have paramyotonia congenita with hypo. I've been told it's rare since it's usually hyper. Acetazolamide severely worsened symptoms. Amelioride alone didn't help, but now on amelioride plus eplerenone, but potassium stays at 3.5.
So I like the initial statement because usually having any form of myotonia, whether it's paramyotonia or myotonia, is an exclusion for diagnosis of hypo-PP. There was one well-documented case that I'm aware of from the group in London, and it just so happened where I told you the special locations where the mutations need to be to cause hypo-PP are also in the parts of the channel that make it voltage sensitive for when the channel should open. So it's, theoretically conceivable you could have hypo-PP from a sodium channel mutation and also some myotonia, but that's only been documented once. If that being the case, I would still manage this with the guidelines for hypo-PP rather than for paramyotonia congenita. I think that would be more important, and it sounds like the eplerenone that this person is on is heading in that direction. It's also well recognized that some individuals with genetically documented periodic paralysis, especially sodium channel mutations causing hypo-PP, that they have paradoxically had worsening on carbonic anhydrase inhibitors.
Okay, and this one I'm going to actually bring up to you because it's a long medication list and I'm not going to be able to read it well, and it's probably easier to read yourself. But it talks about the daughter still being in severe pain with a particular thing. Can you read through that real quick? Or do you have glasses yet?
I have, that's all right. Here they are. Here they are.
Yeah. Sorry about that, but we're going to try. It's this one.
Okay. Let's see. So this one's genetically tested and has a calcium channel gene associated with autosomal, it looks like that. Oh, the one above it. Oh, sorry. All right. So it's several tricyclic and atypical antidepressants and paracetamol, which is Tylenol in Europe. So all of those are fine in terms of no contraindication in periodic paralysis. One of the challenges is there isn't an obvious first choice for the myalgia that occurs, so it's a little bit of working through the usual either acetaminophen or nonsteroidals, or there are sodium channel. If you have myotonia, some of the antidepressants also have sodium channel blocking secondary effects, which would sort of be two birds with one stone. So that would be the way to work through. But none of those were contraindicated for use in periodic paralysis.
Okay, and I'm going to call it out just Liza Christopher because your name's in the chat and that was for you. So just to let you know, because that may be hard to track. All right, I was a Division I wrestler, did judo, strenuous exercise my whole life. I was genetically tested and have the CACNA1S gene associated with autosomal dominant hypokalemic periodic paralysis 1. I have permanent weakness, mostly in my legs. Going forward, what's the best way to mitigate the effects? I have some doctors saying light exercises, others strenuous. Is there a definitive answer?
So the general recommendations are to manage the acute attacks, try to have as few and as mild as possible, first of all, to stay active and to use your own experience with exercise and other programs that you're using to stay fit. So if you're not having weakness after your exercise, then it's fine. You can tolerate that level. It's if you push it to the point where you're having the exercise actually trigger weakness during rest, then you've gone too far. And a key thing to do for that, for hypo-PP, well documented with a calcium channel mutation situation, you want to pre-hydrate, make sure you're hydrated before exercising. And then after exercising, warm down. So walk around for 10, 15 minutes afterwards, because it's the abrupt cessation of vigorous exercise and dehydration. Those two things together could trigger attacks. And managing those is the best approach we have for hopefully slowing the progression of permanent muscle weakness.
Okay, and I've been down in my phone a lot. Are there any in the room? Then we'll keep going. There's one. Oh, yep. I'm coming your way. Actually, I'll come this way on the way to your way.
I have a follow-up on the GLP-1s. So I'm hyper, and I'm pre-diabetic, and currently take dichlorphenamide. So just wondering if a GLP-1, do you think that would be a good thing to maybe start? And if I did, do you think I should also take the dichlorphenamide, continue taking that as well?
Yeah. So, of course, there's good evidence for the benefits of dichlorphenamide in hyperkalemic periodic paralysis as well as hypo. So that's fine. The recommendation would be if either of those is new for you, to take one at a time, be on it for a couple of months, then add the second one. Otherwise, it could be very confusing, and some of the effects are sort of long-lived. As I was alluding to last hour, from first principles, I think these GLP-1 agonists could be beneficial for individuals with hyper-PP, because there are a lot of things that are going to happen that's going to tend to lower the blood potassium, so you might derive a secondary benefit. Again, I don't think it's not the GLP-1 agonist acting directly on a receptor in the muscle or something like that. It's through secondary effects on serum potassium. So certainly I wouldn't see a contraindication there at all. So.
Hi, this is an odd question, but do you ever see the distillation of a diagnostic test that could be placed into like a newborn screening panel eventually that could then basically when the baby's born and they do the newborn screening test, there could be a periodic paralysis test that could be a part of that could do basically, I hate to say yes or no, and then know at birth that there's a possibility. Is that possible, or am I totally not understanding that?
Yeah, so the technical possibility is there to screen for established and known genetic variants that are associated with periodic paralysis. There's one really interesting context in which that could be especially useful. There's a form of myotonia from a sodium channel mutation that's very severe in infants. It causes severe neonatal laryngospasm, and they really can have hypoxic episodes because their larynx closes down so much. And these are extraordinarily rare, so you wouldn't be screening the general population. But say in a family you had one child that had that situation, it would make sense for subsequent children to not wait for the infant to become symptomatic, but to screen as soon as possible. Yep.
Good morning, Dr. Cannon. I have a question for you. As you know, I'm genetically diagnosed, and we've talked before that my mutation is a little odd. Over the past probably 2 to 3 years, it's like I don't have periodic paralysis anymore. My potassium stays at a constant 4.7, and I have undertaken physical therapy treatment to the point where I'm now standing again. Where'd the periodic paralysis go?
So thank you for sharing, Linda. So working with Frank Lehman Horn, it was discovered that Linda has a calcium channel variant that's just below, further down, where the classical ones are that cause hypo-PP. So although very unusual, very reasonable to be a causative mutation, and congratulations to Frank and you for finding that. It is low enough, however, that the same kind of biophysical leak that we can measure in our experiments, I wouldn't predict your variant to cause. And so as a result of that, it doesn't surprise me that your response to potassium or how things are changing with age might be not mapped onto the classical story that we see in hypo-PP. On the other hand, I really like that you shared that because it shows that you should never give up, and that especially if things have impaired mobility and stuff like that, there's still reason to be engaged in therapy and efforts for improvement. So thanks for sharing.
And that is good news. We have a question. My neurologist disagrees with my POTS diagnosis because he thinks it's too rare for me to have hypo-KPP and POTS. I have all the symptoms and my heart rate jumps from 80 to 70 without, this is great, ivabradine. Ivabradine? I-V-A-B-R-A-D-I-N-E. I guess it's a drug of some sort. It's a POTS medication.
Yeah. So POTS is your heart rate going up. It's tachycardia without drop in blood pressure, induced by postural changes. POTS is not an established feature that's an accompaniment of periodic paralysis, of classical periodic paralysis. So even, the status of your muscles can do things like influence blood pressure and venous return to the heart because the tone and force in the muscles affects the caliber of the veins and things like that. But there hasn't been a clear-cut, secondary effect or, warning that people with periodic paralysis should wear elastic stockings or things like that. So again, this would be in one of those cases, I think, that we were talking about last hour, that there are these symptom clusters that, deserve everyone's attention and effort to provide symptomatic improvement. But I'm not sure I could connect the dot and say that the POTS is because of periodic paralysis, because we haven't seen that in a well-documented situation yet.
Okay, this is another one. You gotta put your ears on for this. How do you know if you have PMC and hypo-PP? I have the diagnosis PMC P.PRO 1158 SER, and parenthetical. Does this make sense? And then, but I do recognize hyper-PP symptoms. What types of SCN4A are a combination? What types are only PMC?
Yeah. So I know that 1158 mutation, our lab has studied it. It has the changes in the channel that would make you at risk for hyperkalemic periodic paralysis and paramyotonic ingenita. So it's an interesting point. It's the second question that's come up, that you need to recognize that all of us have fluctuations in potassium. And by chance, you could have hyper-PP and be symptomatic, and by chance, your potassium is 3.5 or 3.2. And I would caution you to jump to the false conclusion that, oh, my diagnosis was wrong. See, I have hypo-PP. These are variations and fluctuations in biology that happen all the time. So be cautious. That mutation has been found in many different families. It's always hyper-PP with myotonia, and this person should follow the recommendations for management of hyper-PP.
Okay. Another tongue twister for Dr. Cannon. In your talk yesterday, you mentioned your lab's ex vivo results for XEN1101, which is a potential alternative to retigabine, I guess, for hypo-KPP patients. Importantly, This compound and other KV7 pipeline drugs like BHV7000 are optimized for distribution to brain, significantly more so than retigabine. Do you think this precludes clinical efficacy in PP, given that little of the drug will reach the muscles, or is there potential for the drug to be directed to skeletal muscles by reformulation?
Yeah, so I haven't looked in detail at the biodistribution data, but usually the problem is getting into the privileged space of the blood-brain barrier. So you have to do tricks to help drugs get into the brain. But the inverse is not a problem. Drugs get everywhere and influence all the tissues. So I would be surprised that there would be a problem of delivery to skeletal muscle by any of these class of KV7 agonist drugs.
Our next question. Our neurologist has decided to not prescribe PP meds beyond KCL without genetic or medical test evidence showing HKPP. Please share advice on advising doctors on clinical-only diagnoses and finding those who will treat based on that alone.
So this is very much a personal choice between the patient and the patient-doctor relationship. And, you know, like I think it's been said at this meeting, doctors are humans too. And so we all have different approaches towards the promise to do no harm, protect patients from adverse effects of medications, because everything is a trade-off. And you might find different answers from different very competent neurologists or other physicians. And so again, that's just a match you're going to have to make because it is kind of a gray area. It's not reckless to use medications for periodic paralysis in those circumstances, but you should always be looking at the trade-offs and assessing, does this make sense?
Yeah, thank you. Dr. Harr.
Yes.
What are the possible complications you can have if you react to the anesthesia without any accommodations for PP? I had a 5.5-hour surgery before I was diagnosed with PP, so no anesthesia accommodations were given. When I woke up in recovery, I had unbelievable pain and pressure in my calf. I had an extremely painful contracture that lasted for months. Is it possible I had a missed compartment syndrome from the anesthesia, or just a complication of nerve damage?
Any thoughts on that one?
So there can be, you know, malpositioning during surgery and pressure palsies and problems that can cause cramps and long-lasting slow recovery periods. It's not too surprising also if the, you know, recommendations, as Dr. Harr has said, it's triggers, triggers, triggers. Make sure you avoid triggering something, especially while somebody is under general anesthesia and, you know, can't provide feedback, and it's hard to tell that you're going downhill there. So it's a little difficult with the available information to tell which of those was happening, but for either situation, whether it's a pressure palsy or a prolonged episode that was aggravated by not intervening properly, both of those should eventually be reversible, but like nerve compression can take months to get better, so don't be surprised by that.
Yeah, we do procedures too for people like back pain and so forth, and we try to kill the nerve so that way they don't have pain anymore, and then within a year that nerve regenerates and so forth. So it's a slow process, but very successful on reversing it given time.
Thank you. Another Dr. Harr, what would be the best approach to convince the anesthesiologist to have IV potassium on hand during a procedure?
I think that your best approach is using the quick reference guide, making sure they have it, because it's not only, it's well referenced and it's peer reviewed. So that's a very powerful tool for anesthesia.
Can the muscle depolarization that Dr. Cannon mentioned yesterday be measured via EMG or other methods?
So you can see the indirect secondary effects, which is when the muscle depolarizes, it loses its excitability. And what you can see with the needle EMG or the surface EMG is just when one of those successful spikes in voltage has occurred in the cell. So there would be an absence of spikes that could be detected in the clinic, but you cannot measure the intracellular potential, that requires special equipment in a research laboratory.
Question here. Great.
Hi. So your laryngeal spasms triggered a question for me. My youngest, when she was newborn, she would have a lot of cyanotic episodes where she'd go unresponsive. We'd have to stimulate her to breathe. We found her blue. Fortunately, I reached out to Linda when she was in the hospital, and she reached out to the experts with PP, and they told her to put on an apnea monitor and sleep with a pulse ox, and we spent her first 2 years like stimulating her to breathe and stuff. So she outgrew it, but she still has trouble with aspiration. Used to it was like frank aspiration, but now it's just like mild penetration. But there was a lot of unexplained like hypoxic episodes. They thought she had possibly like a laryngeal cleft. But yeah, I guess my question is, they continue to do like the exome sequencing on her. All they found is a VUS with NEB and a CAPN3 mutation, recessive. So I guess that's my question. If it was something related to that, would she continue to grow out of it? Because she did have stridor episodes, you know, stuff like that. So.
Yeah, so the number of causes of stridor and breathing problems, of course, is very long. So these cases of severe neonatal laryngospasm were for mutations that cause very severe myotonia, which can be challenging to diagnose in an infant. I mean, you don't easily do a needle EMG and so forth on an infant. But that then persists later in life. Fortunately, these individuals grow out of the risk for the stridor and laryngospasm. And interestingly, there's a developmental change in the types of ion channels and the density that are expressed in muscles. And this is what's thought to occur, why these individuals, usually by the age 1 or 2, have outgrown the risk for this. And it can, these things, ion channels and excitability of muscle and other cells continues to be tuned over the span of life. But it's these mutations of the sodium channel that in the laboratory cause the most severe problem with the channel staying open too much. And so it was one of these good cases of a correlation between the biophysical defect of the channel is one of the biggest we've seen, and the myotonia and the challenges are some of the most severe that we've seen. So there's clearly a strong correlation there. All of these cases and now there have been about a dozen or so that are in the medical literature, they all had classical mutations in the sodium channel that they had detected.
Dr. Harr, would you suggest an injection into my daughter's spine for her ongoing back pain, 18-year-old hypo-PP?
I don't know of any contraindications of doing an injection for the pain relief for someone with hypo. In fact, probably give them some benefit.
My daughter and husband have hyper-PP and have at least 1, usually 2 episodes a day. They usually let the episodes happen. They last 45 minutes to an hour. When they recover, their muscles feels completely normal. If they stop the episode by having something sweet, drinking Coca-Cola works best, the recovery is slow and muscle is weak and sore. Should they stop managing the episodes this way? We have concerns of how this approach the effect that this approach might have on permanent muscle weakness.
Yeah. So that's an interesting observation. Again, usually oral carbohydrates and glucose help hasten the recovery. But, I would always modify any of these recommendations to your own personal experience. And, I think in this case, what I would work on is why are you having 2 attacks a day? That looks like an opportunity for better intervention and management. So if the carbohydrates aren't working, things to lower potassium or trying carbonic anhydrase inhibitor to just not have so many attacks, I think would be the really important thing to do here.
Is a McManus test legitimate if you stop taking your PP meds,
Eplerenone? Yeah.
I'm going to get it, eplerenone, potassium, a few days before, or have do the meds need to be stopped longer than that before the test? And this is a hypo-PP.
Yeah, so this is an interesting topic that we haven't really talked about at this meeting very much, but the electrophysiologic test in the clinic, the patient test to look for evidence of periodic paralysis, is a so-called CMAP long exercise test or McManus test. CMAP is compound muscle action potential. So basically, and in Dr. Sutherland's talk, she showed that the surface electrodes tape over the muscle. You apply a shock with a little metal ball over the skin and can trigger action potentials in the muscle. So what you do is measure how excitable that muscle is at baseline, then have a sustained voluntary contraction for up to 5 minutes if you can do that, and then relax. And the patient then just relaxes and the stimuli continue to be applied, and you monitor how excitable the muscle is by the amplitude of the electrical response, which in a classical case consistent with periodic paralysis will decrease by at least 40% over minutes and then come back. So the challenge with this test, I mean, that's great. Everybody would love to have an objective biomarker that can help determine whether someone truly has periodic paralysis. So the challenge is the sensitivity of the test is quite low, especially if the individual is not having frequent attacks. So the data that's out there, if you haven't had an attack in over a year, even if you have bona fide periodic paralysis with a known mutation, the sensitivity is only about 60%. So 4 out of 10 times you'll get a normal result. Whereas an individual who's having attacks as frequently as once a week, it approaches nearly 100% sensitivity. So those data, again, it's hard to come by these numbers because this is such a rare condition. Those data did not, and that study did not discriminate for whether the individuals were on medication or not. So I think the more important question for going into and considering having a CMAP test is whether you are currently symptomatic, regardless of the medications you're taking. And if you're having problems with frequent episodes, even to your best efforts with medicines, well, don't go off your medicines to increase. You're already symptomatic enough. Just go in and have the test taken. Now, if your medical interventions are highly effective and you want to go for it, speak to your care provider, and you can consider that.
Okay. Can you have both chronically low potassium levels and hypo-PP? This is rapid potassium fluctuations with muscle weakness. Do the potassium levels have to be normal between episodes, or could they be chronically low?
Yeah. So potassium can be chronically low in all of us. It fluctuates. Interestingly, not only does low potassium trigger the events of hypo-PP, but it also changes the way the channels are conducting so that you begin to trap potassium in the muscles itself. So as the potassium is starting to trend down, you get in trouble and the channels misbehave and you start to trap, and then that further aggravates the situation. So that's, again, another one of the sort of cyclical challenges that's going on in hypokalemic periodic paralysis. But the condition itself does not affect kidney function, or would there be an expectation that because you have hypo-PP, your K should be low all the time? That would not necessarily follow biologically.
Next question. Could you discuss sleep paralysis versus periodic paralysis? Is it possible for PP to be misdiagnosed as sleep paralysis? So one of the challenges here is that it's very common for the weakness in periodic paralysis to be commonly occurring in the morning upon first awakening. And this is also a time where the sleep pattern, there is a lot of active dreaming, and you can be in a semi-awake state. And interestingly, your brain goes through active patterns to shut down and disconnect what your motor cortex is doing. And in your dream, you're moving, running, whatever, and if things are working properly, you're not thrashing around, punching your spouse in bed, right? So things are shut off, but sometimes as you're waking up, that mechanism is still in play. And so it's the so-called sleep paralysis from, again, it's misregulation of a normal physiologic process to prevent inappropriate movements during sleep.
And so because both of those happen right upon awakening and they get better in a couple of minutes, it is an area of consideration in the differential diagnosis and trying to piece those apart. The difference would be, the sleep paralysis isn't going to come at other times of wakefulness, and the periodic paralysis can, but there's not otherwise a biological association. Again, the channels that are at fault in periodic paralysis are in the muscles only and not in the brain. So that it's not causing sleep paralysis. They're two separate syndromes.
For Dr. Cannon, I have clinically diagnosed hyperkalemic, sorry, they're bumping it up, hyperkalemic periodic paralysis with a VUS in the SCN4A gene. And then she calls it out, 20:C.2704G greater than A. And then another one, as acetazolamide and albuterol inhaler has significantly improved my symptoms. My doctor diagnosed me based off my symptoms and reaction to my treatments. I'm unsure if the location of my variant is relevant in this. Do you happen to know? And I can bring you that if that's helpful.
Yeah, so she can submit that information through Ask the Experts on the PPA, and I maintain a private database, and I'm happy to help people out with these questions.
That's fantastic. I've been told that, got a couple live here.
Dr. Cannon, I just have a question. What made you choose periodic paralysis as what you're doing for a living?
Great question. So when I trained as a neurologist, I did not have a focused interest in muscle or muscle diseases. And it was after I finished and I was entering training to learn how to do detailed electrophysiology. I was really interested in excitability of cells and how neurons work. And a colleague of mine, Robert Brown, who was one of the authors on the first genetic identification of a mutation, hyper-PP, he came to my lab with a culture dish of human muscle cells from a biopsy of a patient with hyperkalemic periodic paralysis. And none of the mutations had been found yet. But there was linkage, there was statistical inference that it might be a sodium channel problem. So he said, Steve, could you try to record the sodium currents in this biopsy specimen, because we think it might be a sodium channel problem. And we actually saw the channel misbehaving before the mutations were found. This turned out to be M1592V, by the way, people here with that. And when something like that happens, as a physician scientist, the light bulb goes off, and I completely changed direction because this person brought by a dish of human muscle cells in culture. That's what happened.
So I'm hyper, and I've had better success lately with controlling the paralysis, but I've had more, what I'm wondering if it's within the realm of myotonia, because I've had more episodes that are not weak or paralysis, but they're like trunk spasms, but they're like this kind of spasm, but they'll go on for an hour or more, and is that within the realm of myotonia?
It very well could be, and a lot of individuals with hyperkalemic periodic paralysis and paramyotonia congenita have specifically described feelings of tightness and involuntary contraction actually in their abdomen, both before and after attacks. And if it's bothersome to the point that you want to consider medications, I would explore things that are used for myotonia, such as Lamictal or Mixilotine.
Okay, that's really helpful. What was the second one? Oh, I know what that one is.
Mixilotine is the second one. Mixilotine, was first marketed as an antiarrhythmic, and a lot of neurologists were a little nervous about using Mixilotine without buy-in and guidance of a cardiologist. Turned out that there was a study published, use of Mixilotine for neurological conditions, and there were no arrhythmias in that cohort of patients, so it's pretty darn safe. But there's been increasing popularity of using Lamictal because it's used for epilepsy, and so neurologists are more comfortable with that medication.
Okay, and I wanted to ask too, when you mentioned previously some antidepressants that have sodium channel blocking potential, do you know any of the names of those off?
So the tricyclic antidepressant class, all of them have, every drug has a lot of off-target effects, and it doesn't just go to one, but the tricyclics have antidepressant.
Thank you. And I also wanted to tell Dr. Harr that I used your papers and information recently I've had it through 2 surgeries now with my surgery team. And it's just at a regional hospital, but they call in an anesthesiologist from another hospital that took an interest and studied up, and they've done all kinds of things with regional blocks and different things, and it's worked. Like, I actually hugged everybody after the first surgery because I didn't know you could wake up from surgery and be awake and be able to move. And it was amazing. Like, we sung a song together, amazing, because I couldn't believe you could be able to move the same day after surgery. It was incredible. So thank you so much for writing those things. And my team all got on board with it, and it was a totally different experience than I've ever had before. So I really appreciate that. Thank you.
Well, you just made my day.
And you may have just answered this question, which is, have you seen better surgical outcomes when patients pass on the protocols to their surgical team? So, Jamie, that's your answer. Can a single MRI on an elderly person with muscle weakness be sufficient to demonstrate PP type permanent muscle weakness versus standard aging, or does it require previous scans to show deterioration?
Yeah, so as Dr. Sutherland said, the MRI is very accurate for measuring fat and connective tissue replacement of muscle and loss of muscle, but that's what it does. So you have to interpret that in the context of why someone would be susceptible for losing muscle. So you cannot use it as a screening test to say, oh, this person has periodic paralysis. You can use it sequentially in somebody with a known diagnosis of periodic paralysis to say, is there documented evidence of progressive changes as we see in permanent muscle weakness?
This one is, I have breathing muscle weakness at times, sleep apnea, but not overweight, and family members with, quote, delayed recovery from anesthesia, unquote. This is not typical PP, right? Could it be an underlying congenital myopathy or myasthenia layered with PP? How to inform the anesthesia? Of course, clear diagnosis would be the most helpful, correct?
How would you diagnose that?
Yeah. So again, in periodic paralysis, sleep apnea and needing to go on CPAP and things like that is not a, sorry, that's my telling me it's time to go, but that is not an expected consequence and normal sequence of events. Of course, it can happen. These are not rare conditions, and so you could have the coincidence of 2 different things. But periodic paralysis per se has not been associated with that.
Okay, and our walk-off music will be applause for Dr. Cannon and Dr. Harr.